Ma'am, 10th session we are starting with your help and blessings and the support of all of you. Thank you very much for sparing time. And the topic for today is endometrium. As we all know, the endometrium is a very important, it plays an important role in the positive result, not only in IUI, IVF, it is also important in natural conception. It gives us a positive carry home baby rate and live birth rate. So endometrium is very important. Secondly, nowadays, as we have improved with our vitrification programs, nowadays all other centers are doing mostly frozen cycle. And to listen to that, how to form the endometrium, how thick should be the endometrium, what is receptivity, what is the pattern. We are here with our speaker for day, is Dr. Jyoti Bali. Dr. Jyoti Bali, what all knows about you, I know she's a very good leader, good manager, and good academician. And she's a very good orator. So we welcome you, Dr. Jyoti Bali, and now I proceed the session.
My slides visible?
Yes, Dr. Jyoti.
Yeah, I'll begin. Thank you so much for this opportunity, ma'am. I'll begin with this presentation. Well, type of freezing method, vitrification, we know is superior to slow freezing, which in turn is superior to ultra rapid. However, more well-designed and powered studies are needed to further corroborate these findings. This is how the evolution began, and from slow freezing, we moved to vitrification, which changed the game of IVF cycles. FET is an inevitable part of an IVF ET program. It certainly improves cumulative pregnancy rates. We cannot do without it nowadays. And surplus embryos have to be stored. Of course, it is a boon to add to this treatment. Without cost of the stimulation and risks of OPU and OHSS, this gives us a lot of benefits, psychological support for patient and physician. In an FET cycle, what is the advantage? No supraphysiological steroid levels. The deleterious effects of cryopreservation can be negotiated by improved endometrial receptivity, and of course, multiple pregnancy risk will be there. Now, when you're stimulating a patient in fresh transfers, there are supraphysiological levels of E2 because you've stimulated the ovaries. And the fresh transfer, that will affect, and Cochrane review has said when those effects are taken away, there is another hazard of cryopreservation. But in between the overall results in an FET cycle compared to fresh cycle, there is 10% more. That is why, given a choice, we have moved on to FET cycles. Now, with having moved on to FET cycle, what are the protocols that were there and what are existing, what we are using, and which patient to suit for which protocol? Because after all, the practice is now individualized, and we cannot apply one to all patients. It has to be individualized protocol. It has to be individualized, tailored FET program for each patient's history. Now, the type of preparation which exists is natural cycles, modified natural cycle where an HCG trigger plus luteal phase support is given, stimulated cycle using clomiphene citrate, letrozole, or a combination with HMG, gonadotrophins, GnRH agonist, or with an HCG. Other drug which has come into vogue is tamoxifen, which has also been used to prepare endometrial lining. Hormone control cycles where you downregulate a cycle and then use the hormones like estrogen and progesterone for hormonally manipulated cycles. So let us take up one by one as to how the preparations are you can use for which patient, and when you stuck with one protocol, you move on to the other one, and what are the other strategies that one can take up. Natural cycle, yes, in ovulatory cases, frozen ET is successfully carried out after spontaneous ovulation. Young patient, less than 35 years, regular cycles, ovulatory cycles, check progesterone in the previous cycle. So very rarely natural cycles, but then yes, one should know about natural cycle protocol in a young patient, how it can be, where time is a constraint, or you cannot manage the other. Normal endogenous steroid hormone production, because she's an ovulating patient, her ovaries are functioning. So identification of ovulation must be called to the clinic for frequent monitoring. Cancellation rates are as high 6%, ability is reduced. It and flexibility in timing is this. So gynecology out for schedule, which is night duties, cesareans. We'd like to be into IVF, and then we don't like to get out of our comfort zone. But even with that cycle, Sundays are not wanted. Frequent this thing is not wanted. We have to attend DGF seminars. We all want to be a part of the conferences, and therefore we are very control freak people that we IVF specialists become over a period of time. Everything should be planned in the clinic. Your pickup should be timed properly. Your ET should be there because you are dependent on an embryologist also. So your lab functionality with ET being timed, again, there's an issue that your embryologist should be available 24 hours or maybe at least all days of the clinic. So therefore, we like to be, controlling the cycles there. So with natural cycle, you have to plan that all these facilities are available in every center or not available with your timing of your embryologist, because ET, you need the embryologist there, or you will be trained both sides to work as a clinician and an embryologist. So it cannot be used in patients with irregular cycles. In many ART patients, anovulation, irregular cycles, the presence of PCOS and luteal phase defects prevent clear determination of FET timing. For this purpose, the use of stimulated cycles, CC and HMG, is on the agenda. And in fact, CC, we all know, I'll be talking about in the future slides. When letrozole was not there, it has been used. But letrozole is a better drug because it does not have anti-estrogenic effects on the endometrium lining. So monitoring is done using a transvaginal ultrasound, hormonal profile, E2, LH, and progesterone. Start monitoring on day 8 or day 10 of the cycle for endometrial thickness and dominant follicle. When dominant follicle is more than 14 millimeter, monitor using LH urinary kit. Hormonal profile, you can do all these hormones, can be done one day after peak of LH peak to confirm ovulation. Minimum ET for transfer is 7 millimeters. But this becomes very, very cumbersome, to monitor the cycle, and at least using an LH kit, or these are not 100% that you will have. So I have personally never used these protocols. Principles in natural cycle FET: ovulation occurs on the next day after LH peak. E2 drop occurs. Absence of dominant follicle and fluid in POD are the evidence of immediate ovulation. HCG administration is considered as the day of LH peak in a modified natural cycle. So 3, 4, or 5 days of progesterone exposure is given after optimal endometrium is made, and it will again depend upon on what days the embryos have been frozen. So you count from that particular day. So if today the lining is ready, today will be day 0 for me. If it is day 3, it will be 0 plus 3 for the day 3 embryo transfer, or 0 plus 5 for day 5 blastocyst transfer. Progesterone is started 36 hours after HCG/LH peak. Embryo transfer is planned as per day of freezing. I've already said day 3 embryos will be transferred on 4th day of progesterone, and day 5 blastocyst embryo will be transferred on day 6 of progesterone. So you need to synchronize this and remember each patient's record, or recheck before starting progesterone, and then fix up the date of embryo transfer. If embryos were frozen on day 2, thaw them a day earlier. Culture to day 3 and transfer, because personally I do not prefer doing day 2 transfers. I've always done day 3 or day 5. If sometimes in the beginning when the embryologist was not available when I started my unit, sometimes the embryos were frozen on day 2, which I really, I did not approve of. So when the transfer was done, we always like to thaw the embryos one day earlier and then transfer them on day 3. Natural cycle FET, luteal phase support is not required. Indicated with previous history of failure, that's called in modified natural cycle. Usual dose of microdosed progesterone vaginally. Duration of progesterone support, literature says 84 days from the day of embryo transfer. We take it as 9 weeks minimum till the luteoplacental shift happens. So criteria for HCG administration included visualization of a leading follicle more than 17 millimeter in diameter by TVS. In a CC cycle, you can go up to 20 millimeters to 22 millimeters, 20 millimeters, and in a letrozole cycle, 18 millimeters to 18 to 19 millimeters. Serum estradiol concentration more than 150 picogram per ml, progesterone concentration less than 1 nanogram per ml. So modified natural cycle, what is the role of HCG trigger? In patients undergoing natural cycle FET, triggering ovulation by HCG can significantly reduce the number of visits necessary for scheduling embryo transfer without an adverse effect on cycle outcome. Ovulation triggering can increase both patient convenience and cycle cost effectiveness. Stimulated FET cycle. CC, as I said, has adverse effects on endometrium, cervical mucus. Letrozole is a preferred choice of drug. No anti-estrogenic effect. CC plus HMG. HMG increases the E2 levels by producing more of androgen in early follicular phase. Stimulatory effect on endometrium and negotiates deleterious effects of clomiphene citrate. FSH and HMG on day 6, day 8, and day 10 can be given and the lining monitored from there on. And one can again use HCG and then start progesterone 36 hours later and transfer the embryos. So this protocol, yes, there was a PCOS patient I would like to mention where, when we did her pickup, she had about 15, 16 follicles coming up, and her lining on the at the time of stimulation, while her pickup to be done was 9 millimeter triple line. And when she was taken up for FET, lining was not made for consecutive 3 cycles. We had to give her this protocol of Letrose for 5 days and alternate day HMG. Again, her lining came out beautiful. We monitored the follicle in the ovaries, gave her HCG when the dominant follicle size was there, and 36 hours after giving the HCG started progesterone, and the frozen embryos were transferred and she conceived. So this can happen, and this protocol does come in handy if you know how to use it. Baseline scan can be done on day 2 or day 3. A usual baseline scan, you should rule out that the endometrium lining should be less than 6 millimeters. It should be a shedded lining. There should be no cyst on the ultrasound. Then call the patient for serial ultrasound monitoring from day 9 or day 10. If it's a Sunday, you can make it from day 9 to day 10. It will not change. E2 should be optimum of 150 picogram per ml, though I never rely on these hormones. Majorly scan competence is what is important. So I have never got any E2 done on these cycles. 5,000 to 10,000 international of HCG administered when lead follicle reaches 70 to 20 mm. Day of HCG considered as day of LH peak. So 36 after HCG, progesterone to be started. And then from the day of progesterone, you count day 0, and whatever the number of day the embryo was frozen at, we plan the transfer. So these are some of the advantages, disadvantages that modified natural cycle, risk of OHSS, need for cancellation, cost factor, need for monitoring, can be used for patients with irregular cycles, precise timing of HCG is required, prolonged dual hormonal treatment not required if patient becomes pregnant. Frozen thawed embryos can be transferred to naturally cycling women or to women who have been primed with hormone replacement therapy with equal success. So now coming to this hormonally manipulated cycles in frozen eating. We all know that GnRH agonist is a drug which has its mechanism of action where initially there is a flare action of it, where there will be a burst of hormones, and after that there will be a surge which will be downwards and it gets down-regulated. So we have used long protocol in our practice when we began. Now most of the protocols for ovarian stimulation is also antagonist protocol where we do not use down regulation methods of the long protocol. But when it comes to FET cycle, yes, these protocols, the principles are the same, where a GnRH agonist is used for down regulation in cases with functional ovary. When you are doing an FET cycle, there is nothing that the ovary has to do. So you can shut down the ovarian hormones and take the control in your hand. So how is that done? It is done using these GnRH agonists. There are 2 ways to use GnRH agonist. One is where you give a daily dose, but that becomes so cumbersome for the patient. The time length of the cycle is much more. And also, it is non-compliant that every day a patient has to prick themselves. So, but I will give this protocol and then I'll come to what protocol we use in down regulation. So, this protocol also gives us good results at stimulating non-functional ovarian donation cycles. Now, down-regulated hormonally manipulated cycles can be used in where the cycles are irregular, anovulatory or irregularly ovulating cycles. If programming is needed, avoiding weekends, functionally intact ovaries. So, agonist is started after 2 weeks of oral contraceptives. Now, why oral contraceptive should be given? Oral contraceptive always gives you much more control, avoiding of cyst formation in the coming cycle, avoiding disappointment to the patient. So a short period of oral contraceptive, maybe 13 to 16 days, is a good idea if you can give that. It really gives you a good control, no cyst formation, and total down regulation with the control being with you, no endogenous hormones interfering into your cycle. So it is started after 2 weeks of OCP with a 5-day overlap of GnRH agonist and oral contraceptives. This I will explain in my next slides as to how exactly this is done. Mid-luteal, that is day 21, you can start 0.2, 0.5 or 1 milligram subcutaneous daily agonist injection till day 2 of periods. The moment oral contraceptive pill is stopped, there will be an overlapping of 5 days. Let's say you started GnRH agonist, oral contraceptive in this cycle from day 2 of the cycle till 21 days. On the 16th day or 21st, on the 21st, if you are giving 21-day pill, then start on the 16th day this agonist injection. And 5 days there will be overlap. The patient will be on the pills and the patient has started agonist injection. So 5 days, both the things will continue. Then the pill is stopped and the injection continues. Then the patient will have withdrawal bleed after the pill is stopped. So day 2, you call the patient, confirm pituitary downregulation. How is pituitary downregulation confirmed? Similarly, as we used to do it in our long protocol when we were stimulating the ovaries with that. There should be no cyst on the scan, lining to be shut down less than 6 millimeter or 5 millimeters, and E2 levels less than 70. So once the downregulation is confirmed, the control is with the clinician. You then start building the lining up with hormonal administration of estrogen. So this was daily protocol of GnRH agonist. Now the principle remains the same because daily injection to a patient is such a painful affair. We personally use depot preparation, which I will be talking about in the next few slides to come. I hope I could make some sense out of explaining this protocol to everybody. E2 administration, it is used. Dr. Seema, am I audible?
Yes, very good.
Okay. Now coming to E2 administration, well, it is what we should give is we should mimic the physiology, step-up protocol. So variable low-dose step-up regimen is what we should use. See, this protocol of the Cornell FET Cornell program that I have taken from the literature, day 1 to 4 start with 2 milligram, then upgraded to BD dose, then to TDS dose by day 9-10. TVS for endometrial thickness and E2 level assay on day 11. If ET is less than 7 millimeter, increase the dose of estrogen. And QID for 3 to 5 days. And EcoSprin can be added for more of blood flow to the endometrial lining, 75 milligram OD, and reassess. And if it is still less than 7 millimeter, consider cancellation on day 20. So maximum time one should take is 20 days. It is ideal between day 16 to day 20, and maybe sometimes 12 to 14 days, maybe this can be ready. If more than 7 millimeter, continue till day 14, and then one can take up the cycle from there on. So day 15, make estrogen 2 milligram BD and start micronized progesterone. But personally, I do not use micronized progesterone. We use injectables that I will be talking in the next few slides with our protocol. Minimum days of E2 exposure required for attaining endometrial receptivity is 7 and maximum 35 as per Gardner third edition and COG 2006. It has been documented there. So hormonally manipulated cycles are more patient-friendly, simple, cheaper, less frequent monitoring, ultrasound and hormonal profile required, cancellation rate comparable with agonist downregulated cycles, better control and flexibility of transfer timing, can be used in ovulating patients also. Endometrial preparation with exogenous estrogen and progesterone without GnRH agonist is simple, easy and efficient in frozen ET cases with active ovary. But there you'll have to monitor the dominant follicle, call the patient more frequently, start HCG, and if anybody not very trained with the scans misses the dominant follicle or a patient comes a day late, then the entire cycle is wasted. Administration of steroids are similar to downregulated cycles. To suppress ovulation, always start E2 on second or third day of periods itself. E2 can be started OD or BID from luteal phase or previous cycle, also from day 25 to suppress FSH rise and follicular recruitment. This cycle also can be pre-treated with OCPs also for 2 weeks. High dose fixed regimen, low variable step up regimen. I usually follow the more physiological way of doing it is upgrading the estrogen gradually by 9th-10th day of the cycle or 12th day of the cycle. Low variable step up regimen gives more physiological estrogenic stimulation of endometrium that mimics the hormonal pattern of spontaneous cycles and more suitable for endometrial development. So an adequate period of estrogen administration is necessary in order to achieve a subsequent normal secretory endometrium, because there will be receptors which have to come up and that will take some time for it to be primed, and then progesterone receptors will be coming on this for this subsequent transformation of the endometrium for it to be receptive for the embryo implanting. A step-up protocol, usually the duration of proliferative phase in 15 to 21 days, even the thickness has reached 8 millimeter before that time. It simplifies the synchronization between embryo and endometrial development in an ovulatory and irregular cycle, minimize the chances of premature LH surge. It decreases the need for ultrasound and endocrine monitoring, cancellation rate decreases. There is more controlled transfer timing. Disadvantages, well, it is a hypoestrogenic state. It causes cyst formation, can happen sometimes if it is not pre, but then to avoid this, we use OCP pre-treatment along with an overlapping protocols. Prolonged treatment duration can happen. Daily administration of injections is required in the daily protocol. Paradoxical development, the need for maintaining daily exogenous dual hormone replacement throughout first pregnancy, because downregulated cycles will require a good luteal phase support because you have shut down the internal hormones. Now coming to what protocol I have been using in my practice, because that was what ma'am had asked me last time. So same principle of agonist, but changing to convenience. We do not use daily preparation, we use depot preparation. How we do it is, we start oral contraceptive pill for 21 days from the day 2 of the cycle. I call the patient on day 15/day 16, avoiding a Sunday or a holiday of my clinic, and I give them a date that they need to report to the clinic, or they can take the injection and take it in their nearby place. We give them 3.75 milligram on day 16 of the cycle. It can be 15 or 17th day also. One day here and there for convenience is acceptable. And then we ask them to stop the pill as per 21 days pack. So call the patient on day 2 or day 3 of the cycle. Now for the staff, paramedical staff in the clinic or the front desk executive, I always teach all of them that, look, you've given Nupride depot on this date, 10 days from giving the depot, please call up the patient and ask, did she have a cycle? If not, by 12th day, she must come and report to the clinic why there was no period. Let us look into it, whether she's taken the injection correctly, whether she was following OCPs correctly, is everything okay with her lining, or is she about to bleed? What is the endometrium lining? There can always be a call to the patient. And it will be 5 days after stopping the pill. So this has to be very clearly noted by everybody. The 10 days after the depot preparation and 5 days after the stopping pill, plus minus 2 days, the patient should have her periods. If she was a patient who was screened earlier and done a pickup in the clinic, you would know her uterus, her lining, her cycle history, everything. Then start estrogen, 2 milligram BD or TDS dose. Follow up on day 8 or day 9 with ultrasound. Again, one day here or there with your Sundays and holidays. This can be flexible to shift. There is no problem, because totally down-regulated cycle it is with depot preparation. Increase or maintain the same dose. If the lining is less than 6 millimeter, triple line pattern is not there, then increase the dose and call her again after 2-3 days. We also use adjuvants like 75 milligram of aspirin, OD dose, sildenafil to increase the blood flow to the endometrium lining, that is TDS dose, vaginally it is used, and GCSF if the Doppler flows are an issue. Only then we use GCSF. And if the lining is very good, it's triple line, but the flow are less on Doppler study, then we use GCSF along with, so that the cycle is not cancelled and we can take up the transfer. So Doppler study, once the lining is more than 8 to 9 millimeter trilaminar pattern. Intramuscular progesterone / subcutaneous water soluble is what I personally use now. I do not use any vaginal progesterones before the embryo transfer. It is strictly intramuscular or subcutaneous. For day 3 transfer, it is total of 4 days of progesterone. Like for example, today the Doppler has been done, lining is 9 millimeter, triple line, day 14 from starting, or 13th day or 12th day or 16th day maximum. I start progesterone today. Today is day 0 for me. If it is day 3 transfer, it will be on 3 days. Today will be 0 days plus 3 days you can take. So this is how we count. And for day 5 transfer, today is day 0 and then 5 days more. So it will be total of 6 days of progesterone that we will give it to her. And then the transfer is planned. So this 90% of my cases, 90 or rather 95%, I would say, this is the protocol which I have used throughout when I was working at Fortis, when I was doing a batch of maybe 50 ETs over a period of 3 days. This was the protocol that we used to time all the patients in a month at given 3 dates. And whoever did not fall with this protocol, then the cycle had to be studied and for next time manipulated as to what could be done to change the protocol for the particular patient. So this is how a beautiful trilaminar endometrium lining should come up before the embryo transfer. PI value, we do believe in getting Doppler done before transfer in all our FET cycles. PI value, uterine arteries cutoff value is 3. RI, that is the resistive index value in spiral vessels, cutoff value should be less than 0.6. So this is what we take it as. If slightly here or there, I like to use GCSF given in 2 doses 24 hours apart and then starting progesterone. And even reviewing the Doppler study after usage of GCSF, again, 7 patients out of 10 would benefit. So this is the Doppler study which we usually do and look at the blood flows as to how it is showing. And patient also, feels very good having shown them these pictures. Once the scans are done, they also are aware as to how the lining should be, how a triple line can be explained to them looking at these pictures. Blood flow also builds up their confidence and reassuring for the patient. Now coming to this drug, this is there in the literature by one of my friends who's a colleague in IVF is using this drug, though I have never used, but I'm tempted to use in a patient now where I'm finding it very difficult, having tried PRP, having tried everything, and nothing is working, though she had conceived with us about 2 years ago and she aborted at 5 months and nice curettage has been done by a gynecologist, after which she's unable to conceive now because her lining is not coming up. We've tried hysteroscopy, we've tried PRP, we've tried everything. I think this is the only thing left which I have never used, tamoxifen. So I pulled out this paper from role in endometrial preparation because of the receptors being the same, it proliferates the endometrium. Estrogen receptor selector it is. So it is used in a dose of 20 to 40 milligram daily from day 2 of the cycle till HCG is given. To be avoided in PCOS patients and anovulatory patients, progesterone started after 36 hours of HCG, and again an ET can be timed as I have explained in my earlier slides. But I have personally not used, but I'm now going to use this tamoxifen also. It's contraindicated in patients with concomitant anticoagulant therapy, deep vein thrombosis history is there, pulmonary embolism or ductal carcinoma of the breast or any history of cancer. This drug has to be avoided. Can I just take half a minute to have a glass of water? Just give me 1 minute. Akansha? Water. हाँ जी मैम,
वो मकाले वाला स्लाइड तो जरूर दिखाओ.
हाँ दिखा दो मैं इतने पानी पी लेती हूँ इसलिए लगाया था बिल्कुल. I'll read it out. I have travelled across the Lord Macaulay's addresses to the British Parliament 2nd February 1835. He says that I have travelled across the length and breadth of India and I have not seen one person who is a beggar, who is a thief. Such wealth I have seen in this country, such high moral values, people of such caliber that I do not think we would ever conquer this country unless we break the very backbone of this nation, which is her spiritual and cultural heritage. And therefore, I propose that we replace her old and ancient education system, her culture. For if the Indians think that all that is foreign and English is good and greater than their own, they will lose their self-esteem. Their native become what we want them, a truly dominated nation. Coming back to FET evidences, significant effect is of patient age, number and quality of embryos replaced. No significant effect of duration of storage of embryos because now the vitrification method is standardized almost everywhere. Stimulation type does not matter, cause of infertility does not matter. So medicated frozen embryo replacement cycles timed by endometrial thickness measurement alone without monitoring or suppression of ovarian activity are associated with reduced outcome. Good quality of frozen thawed embryos and the trilaminar sonographic pattern of endometrium may be reliable predictors of success in pregnancy. Coming to this Cochrane review, which I just found, 2020 it was taken up from, and this is for endometrial preparation for women undergoing embryo transfer with frozen embryos or embryos derived from donor oocyte. This review I've tried to sum up. It is the latest one from Cochrane Library 2020. It says that endometrial preparation for women undergoing this thing, there's insufficient evidence on the use of any particular intervention for endometrial preparation in women undergoing fresh donor cycles or frozen embryo transfers. It says in fresh frozen embryo transfers, low quality evidence showed that clinical pregnancy rates may be improved with stimulated cycle compared to a programmed one, and we are uncertain of the effect when comparing a programmed cycle to a natural one. Cycle cancellation rates are probably reduced in a natural cycle, although administration of a GnRH agonist compared to without may improve live birth rates. Clinical pregnancy rate will probably be improved in GnRH antagonist cycle over an agonist cycle.
Great.
There is insufficient evidence to support the use of any particular intervention in endometrial preparation that clearly improves treatment outcomes for women undergoing embryo transfers with frozen or derived fresh from donor oocytes. So clinical pregnancy rates may be improved in a stimulated cycle compared to a programmed cycle. And cycle cancellation rates are probably reduced in natural cycle in comparison with programmed. So in fresh synchronized oocyte donor cycle, starting progesterone the day of or day after donor oocyte retrieval probably improves the live birth rate and probably reduces the cycle cancellation rates. Coming to the conclusions for this topic today, endometrial preparation is cheaper with natural cycles, cannot be used in menstrual irregularity. It is not a suitable choice when better control and flexibility in timing is desired. The need for precise determination of ovulation time may lead to anxiety. Cancellation rate 6%, it's quite high. In natural cycles, increased age decreases fecundity, so it should be preferred in younger patients. Patients with irregular anovulatory cycles with functioning ovary can be managed with hormonally manipulated cycles with or without GnRH agonist. Both strategies are equally efficacious, without GnRH agonist being more simple and patient-friendly. Cancellation rates for hormonally manipulated cycles is 2%, and down-regulated cycles, though the literature says 0%, but it's not so. Some patients don't respond when there is so much suppression, and you have to leave them alone then and start fresh without giving a depot or a agonist. So this is the wall of my clinic, one wall which was released on World IVF Day, where we have said evolution of IVF. FET is one of the greatest of evolutions in IVF too, and so is ICSI. So we've come a long way with India also having a wonderful history that, we were just about 67 days behind the world to give our first IVF baby. So we were just 67 days behind UK. Louis Brown and Kanupriya Agarwal, there's a difference of 67 days. So proud to be an Indian, proud to be an IVF specialist, proud to be with DGF under the guidance of two legends, Dr. Azadeh and Brigadier Sharma. Thank you so much for this opportunity, Dr. Seema ma'am also, and DGF West, who's been hosting these infertility seminars. So this is from Baby Soon. Thank you so much, and I hope I could do justice to this topic.
Excellent. Excellent, Dr. Jyoti.
Absolutely awesome. Absolutely awesome. And I think we'll leave Brigadier Sharma to comment. I think your presentation had been flawless. Sir, your comments.
It was an excellent, discussion of various methods of endometrial preparation, and he brought out very rightly that each may not be good for all the patients. You have to select which protocol of endometrial preparation you would require for which type of patients. So that is a very good carry-home message for all of us, that we should use the preparation technique as per the patient's profile. And regarding all techniques are very good, but only problem with the tamoxifen is that sometimes you may find that a follicular cyst forms, and that follicular cyst persists for a long time. And I happen to have a case where tamoxifen created a follicular cyst, and which kept on increasing. Finally, I had to do the laparoscopy to remove that cyst. So that is the only problem, that with tamoxifen you have to be careful, and you must tell the patient that I am giving a tamoxifen. There is a possibility of cyst formation, and if that forms, then possibly surgery may be required in that case, because patient may not take that very sportingly if the cyst forms after that. So one should be a little careful with that tamoxifen, and because the possibility of cyst formation is there, which is much less what I have seen with the letrozole or with the clomiphene stimulators cycle for preparation of endometrium.
My only comment is that, I think the message should anybody who's listening is that the endometrium has to be 7 before you transfer the embryos. I think short of 7 millimeter, you will not find any pregnancy. And what I have seen in our center also, that, the natural cycles are hardly ever used. It is always hormonally manipulated cycle. And but I think I see the merit in your presentation is that it is good to use a depot preparation on the 16th day of the previous cycle. Probably it will do little good. We have never done it, but I think we should try it. This is what I need to tell. We find that this particular protocol works very well in good 95 to 96% of patients. Only in very few patients when you find that, the endometrium is not picking it up, and previously the good endometrium has been there. They probably do not mind cancelling the cycle and take an alternative in the next cycle. So I think this is the what remark from my side. Anybody wishes to make any comment is welcome to do that. Anybody? Yes, Dr. Sunita.
Ma'am, I just want to reinforce this particular protocol where this leuplide shot, a bolus shot is given in the previous cycle is really doing wonders and very good results as far as preparation of lining is concerned. And it's relatively very simpler and easy. And the doctor's control is so much that, like number of days, if you are not available, as Dr. Jyoti said, 9 days, 10 days estrogen. So it's a very, very good protocol, and I do support this, and we do use this.
I find, this particular protocol is used across all PIE center, and I'm sure this is a very consensus kind of a thing. So I think probably looks there is a merit in this. I think, sir, you want to say any comment on this?
Yeah, see, we should know what is the reason why this protocol is better than, just simply giving her estrogen preparation or giving her stimulation and this thing. Now, see, whenever we downregulate the patient, the receptors and all in the endometrium, they change. With the result, you find when you stimulate it, the result is always better. The example for that is that when we have hypogonadism patients, you find that the success rate in those patients is always more because she hasn't menstruated and her receptors were downregulated in that period. And when we start stimulation, so there all the possibly the receptors are all fresh. The response is always better, and the success is always better in a hypogonadism patient when we stimulate them. So the same corollary is here also. When we downregulate the patient by this method or by long protocol, whatever method, especially if it is endometriosis, you may use a long protocol to suppress the endometrium and then prepare the endometrium. So this downregulation actually helps in somehow changing the receptors in the endometrium. With the result, when we prepare the endometrium is also prepared better and implantation is also better.
So I think as a loud and clear message from Dr. Jyoti Bali's presentation is that it's worthwhile trying depot preparation in the previous cycle. So thank you very much, Dr. Bali.
Yes, Dr. Jyoti, please.